Welcome to this technical briefing on strangulation, a comprehensive guide to forensic pathology. This presentation serves as a medico-legal dossier on the various forms of mechanical asphyxia, providing the diagnostic tools necessary to differentiate between various modes of neck compression in a forensic setting. Strangulation is a form of mechanical asphyxia caused by the constriction of the neck by a ligature or other mechanism without suspending the body weight. We categorize these into 6 primary types: ligature strangulation, constriction via a cord, fabric, or wire; manual strangulation, throttling, compression using human hands, including fingers and palms; mugging, compression exerted by the bend of the assailant's elbow or forearm against the victim's larynx; garrotting, an attack from behind using a ligature, which is sometimes twisted with a lever for mechanical advantage; palmar strangulation. Palms are placed horizontally across the mouth and nostrils, reinforced by pressing the heel of the upper palm onto the front of the neck; Bansdola, a specific form of compression using bamboo sticks or similar rigid objects. Asphyxiation follows a predictable clinical timeline. Stage of dyspnoea. Excess carbon dioxide stimulates the respiratory center. Breathing becomes rapid and deep, while blood pressure and pulse increase, and slight cyanosis appears. Stage of convulsions. Respiratory efforts become purely expiratory. Deep facial congestion sets in as veins in the neck swell, often resulting in violent struggling or convulsions. Stage of insensibility. There is a complete loss of logical thought followed rapidly by unconsciousness. Reflexes are abolished, and respiration ceases before cardiac arrest, though the heart may continue to beat for an additional 10 to 15 minutes. Neck compression can lead to death through 4 primary pathways: venous congestion, broad. Soft ligatures block the jugular veins but may allow some arterial flow, leading to rapid rises in venous pressure and cerebral stasis. Cerebral anoxia. Thin cords sink deeply into tissues, cutting off both the arterial supply, carotids, and venous return, causing an immediate coma. Asphyxia, airway obstruction. Constriction narrows the laryngeal or tracheal lumina, forcing the tongue root against the pharynx and folding the epiglottis. Reflex vagal inhibition. Pressure on the carotid sinuses or vagal sheath triggers fatal cardiac arrhythmia, which can result in sudden death without the classic signs of asphyxia. Forensic diagnosis relies on understanding that different structures collapse under specific weight thresholds. Jugular veins, 2 kg, the lowest threshold. Blockade prevents blood from draining from the head, leading to intense facial congestion. Carotid arteries, 4 to 5 kg. Blockade cuts off the primary oxygenated blood supply to the brain, inducing rapid cerebral anoxia. Trachea, 15 kg. Requires significant force due to rigid cartilaginous rings. Vertebral arteries, 20 kg, the highest threshold. These often remain patent even when carotids are blocked, continuing to pump blood into a blocked venous system and exacerbating facial congestion. External signs are often sharply demarcated above the level of neck constriction. Facial features. The face is puffy, edematous, and purple or cyanotic, while the skin below the ligature remains pale. Ocular findings. Eyes are wide open, prominent, and bulging. Conjunctivae are deeply congested with confluent scleral hemorrhages, and pupils are dilated. Oral cavity. The tongue is swollen, bruised, dark-colored, and frequently protruded. Blood-stained frothy mucus may escape from the mouth and nostrils. Extremities. Hands are usually clenched in a cadaveric spasm. Tardieu spots are petechial hemorrhages caused by the acute rise in venous pressure, leading to the rupture of thin-walled peripheral venules. They are most commonly found in lax, unsupported tissues such as the scalp, eyelids, conjunctivae, forehead, and skin behind the ears. Their presence immediately adjacent to a ligature mark strongly confirms the mark was made during life, antemortem. In strangulation, the ligature mark is the primary local sign. Position, usually situated at the middle of the neck or below the thyroid cartilage. Orientation, it is transverse and completely encircles the neck. Skin quality, the base of the groove is typically soft and reddish, unlike the hard parchment-like mark of hanging. Vital reactions. A narrow zone of reddening or bruising is common above and below the groove due to the lateral displacement of blood. The nature of the ligature dictates the appearance of the mark. Twisted/rough cords may leave multiple parallel turns and squeeze skin folds, causing intrafold hemorrhage. Wire-thin nylon creates a sharply defined, deeply embedded mark, only 2 to 3 millimeters wide. Broadcloth/soft fabric, leaves a less well-demarcated mark that may fade entirely if not examined soon after death. Meticulous documentation is required before disturbing neck structures. Document the knot. Note the site of crossover and the type of knot. UV examination. Use ultraviolet light to visualize suspected fading marks from soft fabrics. Trace evidence. Apply transparent adhesive tape to capture microscopic fibers. Measure dimensions. Record depth, width, and direction. Removal protocol. Never untie the knot. Cut the ligature away from the knot and secure the ends with thread. Strangulation is often an intimate, violent assault. Victim's neck, vertical, irregular, or crescentic fingernail scratches are common as the victim attempts to pull the cord away. Victim's hands. Clenched hands must be examined. Fingernails should be swabbed for fragments of the assailant's skin or blood. Collateral trauma. Look for abrasions on the face, blunt force trauma to the head, or fractured ribs if the assailant knelt on the chest.